And it's just a huge honor for me today to be podcast interviewing Dr. Bill Jackson, DDS. He's the COO at Virtual Dental Care. I have been a fan of this guy for so long. I mean, walking through his career, I mean, he was in the dental insurance company. He was the founder of Dental Correct, then Dentalxchange, Planet DDS, California Dental Connect, and now he's starting Virtual Dental Care. Man, you could walk these millennials through 30 years of amazing high-tech dentistry. Bill practiced clinical dentistry for 10 years while founding a small dental insurance company in Los Angeles. He left clinical practice to work with Prudential Healthcare, later acquired by Aetna, where he ultimately became president of the dental division headquartered in New Jersey. Later, he was hired by Wellpoint Healthcare, now Anthem, as general manager, the senior executive over the dental division, and returned to California. During the dot-com boom in 1998, Bill left Wellpoint and founded Dentalconnect, a real-time dental EDI company, which later merged with Dentalxchange. After the sale of Dentalxchange in 2003, Bill helped in the founding of Planet DDS, the developer of Denticon, the cloud-based practice management software, as SVP of Business Development. After its sale in 2016, Bill and his business partner at both Dentalxchange and Planet DDS, Richard Lee, started a quest to address the issue of dental underserved through the use of innovative technology. The result was founding a Virtual Dental Care Inc., where Bill is the CEO. My God, what an exciting career.
It's been eclectic.
Oh my gosh. And I was starting Dentaltown. I decided to start Dentaltown in 98 when you were starting Dentalxchange. And that was the biggest dog in the dental internet space for Wall Street, wasn't it?
It was. It got the most funding of anybody in the dental arena. It was supposed to be those were back in the days, as you probably recall, when search didn't exist. You know, portals were going to be the way that people got on the internet, and so whatever portal somebody went into, that's where everybody was going to get. They were going to buy all their stuff and so on and so forth in those days. So we were going to be the dental portal, doing everything that any dentist could want. It was really one of those mile-wide, inch-deep strategies that Google buried when they came out with search.
Oh my gosh, yes. And that was Time Warner's biggest mistake. They paid everything they had for AOL. Remember that? What year was that merger?
Yeah, about the same time.
Oh my God!
Just before the boost.
Was that the biggest financial mistake Time Warner ever made in their life?
It's pretty hard to find anything in history that was a bigger mistake financially.
Oh my God! So I want to start back early in your career because I've always thought dentist. It's very obvious that dentist and insurance companies don't really play together. I mean, like when I podcast interviewed the head economist, the ADA, I mean, you know, economists, they let them take big, massive data banks and run algorithms through it and try to find order. They don't even have access to Delta Dental's hundreds of millions and billions of insurance claims. It seems like, you know, the sheep and the lion can't really lay down and sleep together. The insurance company, the dentists, you know, they want to get paid, you know, $10,000 for a crown and do one every Monday. And the insurance company, they can't sell insurance premiums to free enterprise that high, and you know they want. So they're structurally competitive towards each other, and they kind of act that way. I mean, it's really hard for me to get an insurance director to come on here because he kind of feels like he's walking in a room of a bunch of dentists who kind of act like a trade union. What was your experience like in dental insurance, and what perspective from the dental insurance from back in the day could you provide to these young millennials that, you know, what's your view?
Well, you know, generally I would say, and you know, I'm a ways away from it at this point, but generally I would say I wouldn't view them necessarily as the enemy. I mean, at the end of the day, there's only so many dollars in the system that are going to be paid out, and those dollars are determined typically by what employers are willing to put in. And employers don't necessarily want to pay, open their pocketbook without some knowledge of how much is going to be spent, and they're going to put a top end on it too. So there is not an infinite amount of dollars in the system. So how those dollars get put out is really the question. I had always felt, and I'm not sure it's possible, but I had always felt that there was a way to bridge that gap, so that if the industry could really understand what it is that employers are doing when they're putting dollars into this system, and everybody could figure out how to do it the right way, that there would be a way to do it. And I certainly experimented with that, and not to get into that today, but there should be a way that it isn't necessarily insurance company wins, dentist lose, or dentist wins, insurance company loses, as everybody anticipates. That just isn't the way it works. And if there was a way that everybody could share in those dollars in a fair way, and I think there probably potentially are, but I don't know that anybody's found it, and I don't think we're any closer today than we were 30 years ago.
Do you agree that the insurance companies and the dentists have kind of an adversarial relationship?
Well, they absolutely do, and it's unfortunate. From the insurance standpoint, it's only adversarial from the standpoint that they don't want the dentist picking their pockets, or actually picking the pockets of their customers, is the way they would say it. From the dentist standpoint, it's the insurance companies trying to hoard all the gold in their pots and not let anybody get it, and it's not that way. Employer groups aren't going to let the insurance companies make any more money than the insurance companies can possibly make. So really, it's this balance that I don't think people understand, and if that education ever got across, and there was the kind of mechanisms that would allow it to work the right way. I do think it's changing, by the way, and that is part of the topic of teledentistry. That's this medical dental integration stuff is going to change financing in somewhat the foreseeable future. At least it's going to begin inching in as people begin to accelerate this dynamic of medical and dental working together. People understanding that if you can't have a healthy body if you don't have a healthy mouth.
So what? First of all, do you remember Ed Judd from back in the day?
Oh yeah.
He was from Missouri, and then he came out to Arizona. And I when I opened up my dental office in '87, first thing I did is called him up and asked him to go to lunch, and he just thought that was so bizarre behavior. I mean, I said, I'm so grateful that you're sending me all this money and insurancing so many insurance claims, all my patients, everything. I just want to buy you lunch. And he could not figure that out. The only thing he could figure out, he was from Missouri and I was from Kansas, and he thought maybe there was something different in the water there. But man, I used to send him a Christmas card every year and say, my God, last year you gave me $400,000. Thank you so much. Can I take you to dinner? What do you want for Christmas? And it was just bizarre how dentists just thought of their own self, and it's like they don't go into Intel and sell a company dental insurance for tens of thousands of employees. They have no idea what's on the other side, and it seems like every other industry, everybody works their value chain. Like my dad owns Sonic Drive-Ins. Man, he went to dinner with the man selling meat and bread and buns and other restaurants. Like he was good friends with all the fast food restaurants across the street from him. I mean, they all work together, and it's just, I'm almost embarrassed at the way dentists get along with insurance companies. Like you can go to the CDA meeting, and here's California Dental Association, Delta Dental, selling $1 billion of insurance a year. You think that guy would be the keynote speaker, and yet you look up the hall and they have some speaker saying, Delta or the devil. And it's like, are you out of your mind? Delta or the devil? These guys sell $1 billion with 9 zeros, and oh my God, it's just embarrassing. So what made you could have gone into anything. I mean, you've been in dental insurance, you could be at a DSO, you Dentalxchange, all these things. What made you pick virtual dental care, and tell us what you're doing?
Well, virtual dental care was really something. Again, Richard Lee, who's the COO or the CEO, I'm the COO. We with the sale of Planet DDS, really before the sale of Planet DDS, we began talking about where can dental technology take the industry next. everything's going to begin catching up. All the dreams that people who are technologically oriented have been seeing are finally coming to fruition. Use of the cloud, use of better data, use of data in a better way, use of technology to run your practices better, letting dentists become the CEO, et cetera. That's all catching on, and it's still got a ways to go, but it's going to catch on and be part of the industry as time goes on. But we said, what is the next thing, and what's the biggest challenge out there that technology could potentially take on, and certainly looking at the underserved. This is a huge issue, and everybody's beginning to notice it in a way that I don't even think 10 years ago people noticed it. What are we going to do with this 150 million people that don't seek routine dental care, and how does that affect their overall health? So we began looking at it. We started working with Paul Glassman at University of Pacific, Dagoni School of Dentistry, who was doing studies on teledentistry, and we had modified Denticon, the company's software, to help him, because cloud-based software for his model of teledentistry is a minimum requirement. So we modified it and worked with him. So we knew about teledentistry, we knew about Paul, and we began thinking in those terms. How potentially could what we've done with Paul be leveraged into something else? We started working with a not-for-profit in Orange County, which is called Healthy Smiles for Kids in Orange County, which is the largest not-for-profit that delivers dental care to on a not-for-profit basis to kids. And we began working with them and looking at it, and they were at the time sending vans out to schools. That was kind of their community outreach. And we said, let's take a look at teledentistry. It's going to be cheaper. It's going to be easier. And this is Paul Glassman's model of teledentistry. Let's go out and take hygienists out into the schools as opposed to vans. Let's give them the equipment that's necessary. Let's gather the records. Let's let the hygienist do what a hygienist can do, but also let's gather diagnostic records and have the pediatric dentists do the diagnosis remotely. So we started that program with them, and it really became somewhat of a lab for us. And the first thing we noticed was the technology was really all wrong. And dental office software is good for running dental offices, at least the good stuff is. Dental office software cannot run a teledentistry practice, number one, and doesn't even give you the tools to do teledentistry, number two. So we've spent the last couple of years developing technology dedicated to supporting teledentistry, not to replace the practice management system, but to fill that huge gap that is between a practice management software, in-office practice management software, no matter how good it is, and what the needs of teledentistry is. So then we began looking at it really with an eye towards the underserved, but realized soon that it was much broader than just the dealing with the underserved. At some point, if you're looking at this stuff, you're going to realize, in some point in the future, every dentist is going to have to be doing some level of teledentistry. Maybe it's only 5 minutes a month. But FaceTime on Apple is not going to on your Apple phone is not going to work for what's considered teledentistry if it's just nothing more than conferencing with a patient. You need to be in your patient record. You need to be viewing what it is that you need to view, whether that's health history, whether it's radiographs, whether it's intraoral photographs. You should be looking at that, and you should be noting down the conversation that you're having. So at a minimum, every dentist is going to have that. And as we begin to develop it, we saw dentists coming to us, which we hadn't even anticipated, coming to us and saying, hey, not a bad way to market my practice. I can put it on my website. I can put it on my Facebook site. That I have this secure teledentistry component. They're used to it with medical at this point, and it's getting more and more. So why not add that as a component to my dental practice and maybe give me a slight competitive advantage in my community? That if somebody's looking for a dentist, and then hey, let's take it the next step. We had another group come and say, can I just send this to all of my patients that says they can get a hold of me online if they need to, if their child falls and cracks a tooth, maybe they just call me up on my cell phone where I can look at it and again, within the patient record, take a look at what's going on with that patient and advise accordingly. We had another group from emergency rooms come to us and say, somewhere around the neighborhood of 2%, 2 to 3% of all emergency room procedures are dental related. the emergency room people have no idea when somebody comes in with a dental problem. So the ability for them to just flip up a laptop and bring a dentist in to advise or do a diagnosis or at least a consultation remotely would be a huge win for them. So they began asking us, how can we use teledentistry? And then in came the medical groups who said, we recognize that the cost of chronic disease for diabetes, the cost associated with hypertension, the cost associated with Alzheimer's when people don't have good oral health, potentially there's a way to use the technology you've developed and potentially bring that into healthcare facilities, whether that's medical groups, whether it's hospitals. And then we even had one medical insurance payer come to us and say, could you work with us with our Alzheimer's patients and potentially cut down the overall health risk associated with periodontal disease? So all of these things are emerging from something that we thought was just going to be primarily focused on dealing with the underserved, which it still is. But there's this whole new world that's evolving from that.
Yeah, we did a podcast number 758 on Planet DDS with Eric Geiske, CEO, founder and chairman of Planet DDS, Blake Rice, and Orest Bauer, DMD. Are these your partners?
No, they purchased the company, and they're doing a really good job with it. They have taken it to. We thought we did a really good job, and while Richard Lee's still involved with the company, I'm not. But they've taken it to a whole new level, and they've done a great job with what they're doing.
So they bought Planet DDS?
Yes, correct.
And so now, is your software? Does it work best through Planet DDS? I mean, is that your main cloud-based computing software for the virtual dentist, the virtual dental care?
Well, again, what we built was to fill the gap between the practice management application. I mean, if we learn nothing else at Planet DDS, we learned that dentists are not going to replace their practice management software easily. And I'm painting with a broad brush, but that is all sectors, all segments of the industry that would rather stay with what they've got for reasons that we could talk about for hours. But we recognize that coming up with a full-blown practice management system devoted to teledentistry was not going to take off very quickly, but also totally unnecessary. But we did build it with the anticipation that we would need to interface with other applications. And we also built it with recognition that it didn't have to be just within the dental industry. Again, if a dental office is sending hygienists into a hospital or into or working with a medical group, the hygienist that potentially is going to be on site in that group needs to be able to communicate with everybody in that facility too when you're talking about medical dental integration, not just the dental practice management system back at the bricks and mortar office. So we developed it with, we used to call it open architecture, but the ability to interface with a number of different applications and billing systems. So we didn't want to limit it. And it's not just limited to Denticon. And anybody that has the APIs to integrate with at this point, we will and are probably in the process of beginning that now. Other entities, again, we're totally open and will interface accordingly.
I think Open Dental is the fastest new player because of this, because it's open. I think Dentrix and Eaglesoft, you're right, they're the two biggest tigers in the market. I mean, probably half the dentists in America have either Dentrix or Eaglesoft, but it seems like those are closed systems, and it seems like the new love child in practice management software is Open Dental. Have you reached out to them?
No, but again, I mean, there's a reason it's called Open Dental. I mean, the fact that they're open source allows us to be able to get into it without too much difficulty. We're pretty familiar with Open Dental. Dentrix does have APIs. You can get into Dentrix, not so Eaglesoft. Planet DDS is developing APIs too. So these types of interface opportunities are getting more and more all the time. And I think anybody who's going to play big in that industry is going to realizes this. The folks from Shine or Dentrix recognize that even Ascend is going to have to open up to that too.
So, these kids, when I got here 30 years ago, Arizona didn't have a dental school. Now there's two private dental schools, Mesa and Glendale. It's $100,000 a year to go. These kids are walking out $400,000 in student loan debts. They're listening to this right now and they're saying, "Is this a business model?" I mean, what are you telling dental graduates $400,000 in student loans who are interested? Can virtualdentalcare.com and teledentistry is that a business model that can help them pay back their student loans and be profitable?
We've seen it, and in fact, we're in the process of contracting with dental offices now, just with that thought in mind, or at least the thought of increasing their footprint. So we've actually developed in California the equivalent of a DSO for hygienists. So the hygienists work for a professional corporation that we manage. And we'll send those hygienists out into community locations. Again, this was anticipated that they were primarily going to be going out to the underserved, but it doesn't have to be that. And in fact, we're already talking to businesses that want the convenience of hygienists coming into their locations so that they don't lose their employees all day long. And these aren't huge businesses; these are relatively small ones. And this is a way that the hygienist can actually work with, I won't say for, but work with the dentist, the local dentist who's going to be the hub of or the receptor of. So what's the hygienist doing out there? The hygienist is doing what a hygienist can do legally on a state-by-state basis. In California, mostly that means cleanings a little bit more. But generally speaking, they'll do the hygiene, the preventive stuff, and then they'll gather the diagnostic information. So they're carrying handheld X-ray equipment, whether that's Nomad or something else on the market. They're carrying digital sensors. We give them cameras, intraoral cameras. So they're gathering the diagnostic information. That goes into our software. The dentist then is notified that there's data awaiting, and they sign into the application. They can do the treatment plan right in the electronic dental record there. And the patient gets notified. So the dentist then is able to expand his or her practice by doing the diagnosis and treatment planning locally, or heck, they could do it at home if they want to. But also, if further treatment is needed, which is depending on the demographic, maybe as much as half the people need further treatment, and that's a referral source into their office. So by working with this, if you will, outsourced network of hygienists, dentists can in fact build a referral source that's channeling into their office. They could do it on their own, or they could work with us. But one way or the other, it is a way to expand the footprint and patient base of their practice, and probably the value of their practice too.
And what's the dental hygienist DSO? What's that called?
We're just working. We didn't brand it intentionally. We're just working with a dentist who owns the PC.
Do you see the hygienist? You have these the Smile Mobiles or 2-chair dental facilities on wheels. Who makes those for you, and is that a big part of this plan?
Well, it's mobile to the extent that the hygienist is rolling it in like on a suitcase. So this is totally easy to deal with.
So the wheels are on the suitcase. It's not like an RV or anything.
No, those are too expensive.
So, if a dentist has to go to a rural area. Where are you buying these two-wheel Smile Mobiles that the hygienist carries in on wheels? Who's making that for you?
We've worked with a medical mobile cart company called Core 3 that we've been working with, although there's others that do it too, and we're looking around. We're trying to find the best possible, not only for ourselves, but for our partners too who want to get into this. But
Core 3 at medical mobile carts, those are the best ones for you now?
Yeah, they worked with us and developed specifically to our requirements. There's a couple different models. If you're going to be in an emergency room, in a hospital, in a medical facility, you're going to want something that's kind of substantial and you can roll around. If it's going to be a hygienist going into a school, if it's going to be a hygienist going into a business, that's going to be something that the hygienist is going to need to be able to carry him or herself, and that's needs to be a little bit smaller and a little bit more compact. They all need internet access because we've got real-time capabilities of if you want to dial up and bring the dentist into it, you can. If you want to bring a specialist into the conversation, you can. Everybody's looking at the same record that way.
Are the hygienists, you said they're doing cleanings and x-rays with digital x-rays and the Nomad handheld x-ray carrier. Are they doing a lot of SDF, silver diamine fluoride?
That is up to the dentist to do the diagnosis. We don't get involved in the clinical treatment. If the dentist who is doing the diagnosis recommends that, then yes, the hygienist can go ahead and do that. Now, I need to emphasize too, this is a state-by-state regulatory climate around what the hygienist can do. And right now, there's only 7 states that would allow the model I just described.
What
now,
7
that doesn't
states are
preclude
those?
all the other stuff. That doesn't preclude all the other stuff. The dentist doing, marketing for his or her office. It doesn't preclude the ability to go out to an emergency room and market yourself and say, hey, call me in the middle of the night if you want to, or, for the younger dentist that's trying to build a practice. So that's not precluded anywhere in the country. But if you're going to work with hygienists out in the field, that is definitely a state-by-state issue.
And what are the 7 states?
Oh, I'm going to get them wrong if I say off the top of my head. I know, of course, obviously California can do it. Oregon to some degree, Hawaii to some degree, Wisconsin, Colorado, and see, I'm already missing 2.
California, Oregon, Hawaii, Wisconsin, Colorado.
Yeah, and there's going to be more. There's a lot of pressure right now because of the fact that all of these issues are coming up. The cost of the healthcare system, not just the dental side, but the cost of the healthcare system to not bringing the underserved, not giving routine care to the underserved. Big issue. So every state is looking at it on some level as to, and generically it's called mid-level therapist, MLTs, or dental therapist, DTs type of legislation. And conversations are going on all over the country.
And this is highly emotional to the dentist. I mean, you say dental therapist, and I'd say 80% of the dentists will blow a fuse. And when something like this, historically, whenever you have something come into an industry and is disruptive, there's big opportunities in front of you. And I've lectured in states that have dental therapists, and most of the dentists tell me they love them because they used to have a couple of hygienists doing all the cleanings that they didn't want to do, so they could do root canals and crowns, whatever. And now they have dental therapists doing the operative dentistry, and they say, my God, it's great. The first 2 rooms are cleanings, and then in room 3 and 4, a dental therapist goes in there and numbs up, does the whole filling. So again, it's just building a team. It's leverage. It's like, why would you want to do an MOD filling when you could be doing a molar root canal? So don't you think dental therapists touch some type of button with our dental homies and makes them blow a gasket?
Well, yeah, I think you're underestimating when you say 80%, but I think it's even more than that. But I would say you're absolutely right. And I'm not even going to discuss the scope of what activities they could do. I mean, let's just even leave it at preventive services. Let's not even say they go into the operative world. But it doesn't matter. Whatever the spectrum is going to be, I would say, doctor, get ahead of it. It's going to happen. So why not get ahead of it? Why not be able to, as you say, there's going to be opportunities. So why not take advantage of it while those opportunities are emerging? I mean, putting in your heels and digging in your heels, trying to stop it and hoping it goes away probably doesn't make much sense in this arena, since it's such a big issue politically.
We had another teledentistry podcast, episode 1078, The Future of Teledentistry, with Dr. Maria Constatter. Are you familiar with her?
No, I'm not. I've heard the name, but I don't.
Yeah, and I feel sorry for her because she's from Kansas City. So last night she watched her Chiefs lose in the last few seconds to the Patriots. So she's probably given up all over the future of teledentistry. It probably took a step backward in Kansas City. But she's got a big group in teledentistry. I mean, there's going to be something here. And dentistry, one of my beefs with dentistry all along is that it seems like it's always been more focused towards the all on 4 than the all or none. And a lot of them do it for business reasons because they think there's more money in Ruth Chris Steakhouse than there is McDonald's. And I'm there to tell you that the bottom half of the market probably has more business opportunities and more needs and less competition. Aspen Dental is one of the only DSOs who actually I think has a plan where they have a focused market. I mean, Aspen Dentistry is always rolling out where they ain't. They go to the underserved, they go to where it's Medicaid. And for some reason, you go to these big dental conventions, they want to have all these prosthodontists talk about these big $25,000 an arch all on 4, but no one wants to talk about teledentistry, Medicaid, treating the poor. Do you think there's just as much business opportunity in all on none versus all on 4 and teledentistry for nursing homes and Medicaid as there is in setting up a cosmetic practice in Beverly Hills?
Well, I think about it this way, and how many people have approached you with business plans as they have me? That what is the first thing I look at when I'm looking at a business plan is what is the demand? I mean, if on one end of the spectrum, if you have to create the demand, forget about it. I'm not even going to talk to you. You're going to be scraping on the hillside for 2 years before your fingers find a place to hold on to. On the other side, if you can find something that is already in demand and the demand hasn't been met, my gosh, you're going to take off. And that's exactly what's going on in dentistry with the underserved. I mean, you got dentists who are focusing on the 55 or 60%, certainly no more than 60% of the people who can actually pay or have somebody pay for them. And they're totally ignoring 40% of the market. That's 145 million people in this country. And the 145 million people, not all of them don't have dollars associated with them. So if there is a way to monetize that 140 million people, first of all, our system isn't big enough to the capacity in the system isn't big enough to take it on. But even if it could take it on, my gosh, just look at the opportunity for somebody that can figure out how to make it work in an area where the demand is not only there, it's huge. And there's a lot of people seeking the solution. So yes, absolutely, there's opportunity there.
That was really profound what you just said. In fact, this is my phone. I'm not texting my kids. But why create demand when you can just fill demand? I mean, that is just profound. So many dentists are into trying to sell these big cases, and you're saying why create the demand when you can just fill the demand? Right?
Yeah, absolutely.
I mean, that is very profound. So what are my homies going to find when they go to your website? When they go to your website, virtualdentalcare.com, what are they going to find? What action should you give them? What should they do?
Well, what they're going to find now is that we're right in the middle of changing our website, and in a month it's going to look different and it's going to say a lot of different things, but they can still find us. And there is a form that they can get in touch with us. And again, what I would do is invite anybody. Again, we're limited from a regulatory standpoint to talk about the hygienist going out and expanding the footprint of the dental office. Although in those states where that's doable, we welcome the discussion with anybody. But anybody who wants to begin to get their feet wet with using teledentistry as marketing. We've learned a lot about that. We've seen some ways that potentially insurance companies, both medical and dental, are going to want to interact with them. So learning about, and again, what I would say is even learning about it at this point is important, because if they can stay ahead of this, everybody's going to be doing it. I don't know if that's 10 years. I don't know if it's 5 years, but at some point, everybody's going to be touching teledentistry because the patients are going to demand it, and potentially insurers are going to demand it. So I think that learning as much about it as they can early on, it would be great. And for us, talking about it is what we're doing right now. I mean, we're gearing up. We're getting funded. We are going to go big at some point once we feel comfortable that the industry is ready for it. And we're not going to be the only ones. So there's going to be a lot of talk about this.
So there's a lot of private equity I mean, KKR just bought 56% of Heartland Dental. Do you see the private equity appetite for dentistry still growing?
Well, certainly in the DSO market, and the technology market is heating back up again. There have been any number of reports. I'm getting calls from private equity people about revenue cycle management. I'm not really sure why, but obviously people are exploring it. Again, just the whole cloud-based dental practice management industry has. Again, I don't know whether there have been P&E reports that have gone out, PE reports that have gone out about it, but again, I'm getting calls at a much more frenzied level than I have been for the last couple of years. So I think there's a lot of money floating around. There's a huge amount of money floating around in telemedicine. So every now and again we'll peak. So people say teledentistry, what's that? And they'll call us and talk to it. So I think there's going to be some money around technology and dental going forward quite a bit. Actually.
Talk about teledentistry program takes oral care outside. It all started with Dr. Paul Glassman, DDS, MA, MBA at the University Pacific. This is the virtual concept that Dr. Lisa Bazzetti, dental director at VGMH, was talking about. Talk about Paul Glassman and what his thoughts are on all this. Is he a friend of yours?
Well, Paul was, and he's one of our advisors, but Paul was one of, he's the pioneer. If you ask somebody who's the pioneer of teledentistry, they would say Paul Glassman. And again, his initial approach was, how do we send people out into the community to help deal with the underserved? And there were a million questions when he first started. Now you as dentist, me as dentist, we might say, hey, look, I can take a look at some X-rays and some images, some photos remotely, and do a pretty good job of creating a diagnosis. And certainly in the insurance world, we had numerous dental consultants looking at X-rays and making some sort of remote diagnosis. So that's been going on for years. But Paul needed to prove it. So Paul actually, from an academic standpoint, was the first one to put together that, in fact, a dentist could make a reasonable diagnosis and treatment plan based on X-rays and images. And so he proved that, and that took a lot of the bite out of people who would go to regulators and say that this is dangerous. How does anybody know that it's going to be the same diagnosis remotely that it would be in the office? So he took the bite out of that. He personally went to a lot of regulators and still does, talking about the value of teledentistry potentially to the underserved. So his model, again, in this, it's not overly unique anymore, but his model was send hygienists out, let hygienists do what hygienists do, and let them, including in California, by the way, interim therapeutic restoration, so they can actually scoop out decay and put in some sort of fluoride temporary. And, in kids, that may be permanent as far as that restoration goes. But that helps a lot out in the community, too, in dealing with caries. But at any rate, that was what he studied. And then he's put together numerous programs statewide. And he's a national lecturer, international lecturer, for that matter, on this type of delivery system.
Another pioneer in teledentistry is Dr. Dorota Kapachika Kitarowski, DDS, MPH. I'm sure I butchered that name. I'm sure it's 100% chance it's Polish. Dr. Dorota Kopi, are you familiar with her? Kopicheka Kitarowski, University of Rochester, who says that the missing piece in telemedicine is dentistry. Are you familiar with her?
Again, the name, not the person.
Yeah, I mean, it's all over the place, and I think that I think dentistry, whenever there's a disruption, you really need to look out and see what's going on. I also think a lot of this telemedicine, I think some of the 4,000-pound gorillas in the room, or the 4,000-pound elephant that no one talks about, is 4.5% of Americans will finish out their life in a nursing home. And the data is coming in from the nursing home that they're getting about 1 root surface cavity per month. So once grandma's been in there for a year, she has 12 root surface cavities, which just grow crazy, and there's a big market for that. I've gone to several nursing homes in Arizona and just follow them around for a shift. You got to get the right nurse that is open to it. But I mean, it's just appalling when what I saw with my own eyes is this. These nurses, they seem to be small people to begin with, and they have an entire wing, and they've got to bathe and feed and eat and give medicine to this entire wing. And when it comes down to the toothbrushing thing, all I saw with my own eyes was a toothbrush, a little pea of toothpaste, back and forth on the front 6 teeth, spit in a Dixie cup, and that was their oral care regimen. And to have someone going in there, teledentistry, and doing a thorough cleaning, however often that is, or putting some SDL, silver diamine fluoride, on those root surface cavities would be amazing. And the other 4,000-pound elephant that people don't want to talk about is the sedation. That when these kids, these 140 million people you talk about that aren't really in the dental system, when that 2-year-old needs 8 pulpotomies and chrome steel crowns, and a board-certified pediatric dentist and a board-certified anesthesiologist take that kid to the OR and put him under, that oftentimes doesn't turn out right. I mean, it's When you do an IV sedation, you want to only do people between like 16 and 60 that are healthy. You sure as heck don't want to be doing 2-year-olds. I mean, even the 3 publicly traded dental office companies around the world, 2 in Australia, 1 300 Smiles, Pacific General Smiles, and there's one in Singapore, Q&M. Their lawyers, when they did their DSO and went public in Asia, their lawyers said, you're not even allowed to do this. I mean, they just exit out of their business model. There's no IV sedation by anyone under 16 over 60. So what you're talking about really fulfills a huge black eye in dentistry, and that's underserved for nursing homes. And also in those nursing homes, if grandma and grandpa, if they're not in there for dementia or Alzheimer's or whatever, they got rheumatoid arthritis. They're in a home for a reason. And brushing and flossing all your teeth, what percent of people in nursing home do you think don't even have the ability to properly brush and floss their teeth every morning and night?
Well, it's anecdotal, but it's, I've seen an Alzheimer patient that has forgotten how to hold a toothbrush. And what you're talking about is quality of life issues that I think anybody that's involved in dentistry is aware of, and it is a quality of life issue. And who wants our family members to have poor quality of life if they don't have to? But it's also a real dollars and cents issue to the healthcare system. We've got a contract with a Medicare Advantage insurance company that has hired our hygienist network to go into Alzheimer homes to periodically clean the teeth. And they're not doing it out of the kindness of their heart, although that's part of it. They're good people. But at the same time, the quality of life issue is a side event. It's the dollars that are in the healthcare system that they're trying to manage as best they possibly can.
Yeah, there's a very neat thread on teledentistry on Dental Town, and a lot of these people are saying it works because Medicaid, there's many ways, when you go into these nursing homes and encounter as an exam, a prophy, a denture adjustment, a post-op check, and there's just people, one guy says, when there's money available for Medicaid, there'll never be a shortage of dentists figuring out how to utilize this in their business plan. So it looks like this is going to take off. Do you see anything in the near future that's going to 10x it? I mean, they always talk about in Wall Street, like, you look at a bunch of companies that go into a new technology and you just watch them, then all of a sudden one will have a 10x outbreak, and then historically that is usually the company that got it right. Do you see anything that's around the corner that could 10x teledentistry?
Well, we'd like to think we are, but that's, I think the component that's missing, and you're not going to find it in your thread because we've seen it, and that is the whole technology piece of it. I mean, as an industry, dentists have done a really good job of working around poor technology, right? I mean, what determines what a dentist calls success? It's clinical outcomes, right? Whether that is financial clinical outcomes or the quality of their work. They're not too concerned about the quality of their data. They're not too concerned about the quality of their business analytic tools. So as an industry, I can paint with a broad brush and say that it's an industry that is used to working around poor technology and or using technology poorly and working around that. So I think we've already seen the beginnings of that in teledentistry, of where somebody thinks they can utilize some existing application that's out there in dental and use it for teledentistry. They're not going to be able to. What you're reading for the most part as you're going through that is I wouldn't even call it teledentistry. What you're reading for the most part is either a hygienist or a dentist going into one of these facilities and doing care. Teledentistry to me means that a hygienist, and again, I'll use the dirty word dental therapist, goes into these facilities as potentially a lower cost alternative to sending in the dentist, and then communicating with the dentist, who then becomes almost like a specialist. If further treatment is needed, then further treatment is arranged for. But the dentist then becomes almost like a specialist, but you need special technology to do that, and that doesn't exist. That's why we saw a great opportunity to come out with technology that just that could fill this gap of where you can in fact communicate. Our technology allows you to communicate real time. So in a secure setting, in a way that I can bring up the x-rays. You and I can both be looking at it. In fact, we can bring in the patient. We can bring in the hygienist. We can bring in an endodontist. Everybody can be on the same screen looking at the same record at the same time. That's teledentistry, not just going in there with a record and maybe writing something down and calling somebody on the phone or showing somebody on FaceTime in an illegal, unsecure arrangement. But so the major piece that's missing that we think we bring to the table, and that's what potentially gives us first mover advantage in this industry, is the technology and this unique delivery system of a DSO hygienist. That's not out there. If a dentist tries to do this on his or her own, it's doable, and with our technology, it's potentially doable. It's just much more difficult. They don't have that expertise. They don't know how to hire a field force and manage a field force. They don't know what technology to choose from a software standpoint, from an equipment standpoint. They can investigate all of that, and they can bring people in, and they can hire consultants, or they can hire an outsourced network, which is going to probably make them more money in the long run. So these are pretty unique things that we bring to the table related to so-called teledentistry.
You know, it's so interesting. I mean, you're like one of the biggest high-tech guys that ever lived in dentistry. I mean, really. I mean, you're a dentist for 10 years. You got your DDS from University of Southern California, went into the insurance companies, Dental Connect, Dentalxchange, Planet DDS. I mean, really, you have been at the forefront. And I have to say that most dentists have no idea they've spent their whole career working on poor technology. I mean, I was saying 30 years ago, my claim to fame was that my dad's cashier at Sonic Drive-In had more practice management data than I had, 20 years later running a dental office. And just the fact that their practice management software isn't hooked to Peachtree or Quicken or Microsoft Great Plains Accounting. I mean, they don't know their number. And then when you look at they're all the dentists are all upset this weekend. And there's this thread blowing up on Dental Town called Root Cause. Did you see that Root Cause, that documentary on Netflix?
No, I didn't.
Anyway, Root Cause is it's a very successful movie that's on Netflix, talking about how what do 98% of all cancer patients have in common? They had a root canal, and they're interviewing all these holistic dentists saying that those teeth got to be extracted, and you got to, of course, spend all this money, get all this stuff out of there. And the dentists are just blowing up that, that these holistic dentists, they weren't showing research. They didn't interview anybody who is, an epidemiologist or, just a sensational movie. But I was looking at the root cause of why this movie Root Cause can exist. And again, I said it at the beginning of the show. I mean, Delta Dental, what percent of all the insurance claims since World War II do you think Delta Dental has done? A quarter?
Well, I mean, there's Delta Dent, they're state by state, although right. that's changed somewhat recently. Well, that's probably pretty high, but yeah, you can go that high.
Okay, so if they have a quarter of all the claims for the last half century, I mean, that data could prove whether community water fluoridation works or doesn't work. That information could tell you in a minute if people had root canals had a higher increase. Cancer or whatever. I mean, dentists, they think they're very high tech because they have a CBCT X-ray machine, they got an intraoral camera, they got an iPad, they have all these little toys. But as far as any utilization of the macroeconomics of the dental industry, $110 billion U.S. industry, they don't have a clue to that, and their own accounting. It's really funny how they think they are so high tech, and you and I both know they've spent their entire career in low tech and don't even know it.
Well, yeah, the high tech to them, like you say, is the iTero or something like that, which actually pretty is high tech. I've got to give them credit for this stuff that's come out from clinical usage. But as far as information technology usage, that's right. And by the way, I got to throw in here, thanks for the kudos on me and technology. But I was very fortunate 20 years ago to meet Richard Lee, who is the founder of Dentalxchange that my company merged with, and the founder of Planet DDS, and I've been working with. Without that relationship, you probably wouldn't be talking about me and technology at the same time. So let me throw that in.
Well, let's get him on the show. Does he want to come on the show?
He probably would.
Well, have him come on the show. He wasn't on that Planet DDS one, was he?
No, I doubt it.
Yeah. So, again, like you said earlier, though, the dentist chief. I mean, a fire department. Look at a fire department. I mean, imagine if I just retired from being the chief of the fire department for 50 years, and I said, well, when I started, there were 2 fires a year, and last year half the town burned down. You would say the fire department did a bad job. The fire department has outcomes. It's how many fires are there, how many do they prevent, and in the 30 years I practiced in Phoenix in Ahwatukee, I've only seen 1 house burn down every decade. And when I talk to firemen that come in my office, they say they're basically ambulance drivers. 90% of all their calls are healthcare. But dentists have to look at outcomes. And again, with that data, they are trying to build a business and pay back their student loans. But the purpose of a dentist is to lower the disease, missing, and filled teeth of a region. And I think that the amalgams that we were doing in the 80s probably last twice as long minimum as the composites we're doing today. Doing preventative dentistry in a town without community water fluoridation, and the dentist doesn't provide access or Medicaid or Medicare. I mean, it needs more macroeconomic data so the country can decide, are these 211,000 Americans who have an active license to practice dentistry, are they doing a good job? We gave them 110 billion. Are they reducing disease, cavities, caries? Are they making an impact? And that doesn't seem to be where the focus is. It seems like the focus anymore is, I just got completely taken to the cleaners by all these private dental schools. I'm $400,000 in debt. How am I going to pay back all these student loans when they're out there on the front line supposed to be treating disease, missing, and filled teeth? What is your thoughts on that?
Well, and I'd take it a step farther, and that is let's include medical into that, because there is this continuum that needs to be focused on, and the outcomes measurements between dental and medical need to be better too. What can you say? We're healthcare professionals. That's the who went into dental school saying I want to make a lot of money. People went into dental school because they wanted to help people. They wanted to help health outcomes. But you're right. You get put behind the 8 ball with all the debt. That 400,000 probably doesn't even include their undergraduate. And talking at a consultant get together with some dentists a couple of weeks ago, they said it was brothers who said, "Boy, would we be happy to have only 400,000 in debt." so yeah, I mean these poor kids are stuck with trying to figure out how to get enough money to pay stuff off and live a reasonable lifestyle at any rate.
So for action, are you looking for people to join your team right now today? Talking to the ones in California.
Well, California is where we're starting. Our technology can go anywhere, of course, because it's simply technology. The people that we're working with right now, it's all very workable. But any dental technology, any technology really, but any dental technology has to mature. So we recognize that we've got a few more months of maturing, and we're really looking at this point to work with beta testers that we're probably not even going to charge any money to for a while, just to get this stuff off the ground. Your 10x analogy that you were talking about before comes with knowing that what we've got works, knowing with what we've got is good, knowing that it's solid and that it produces the outcomes we want it to produce. So we're probably going to be looking for the next 6 months to find the right kind of partners. We want to make sure that dentists who use it for marketing purposes actually do get patients coming in because of it. They are able to retain existing patients because of the fact that they've got cutting edge technology that somebody else maybe in their neighborhood doesn't. We're looking for people that are forward looking, that as regulatory restrictions ease, that they can expand the footprint of their practices by taking it beyond the wall, by taking the care that they offer beyond the walls of their practice through the use of hygienists in some form. Or dental therapists. So at this point, we're looking for to use the words of my business partner Richard. There's a funny shaped door that we've got, and we're looking for people that can fit through that funny shaped door. And these are going to be the early adopters. These are going to be the people that will end up being advocates of what we're doing in a positive way.
So, are you in Irvine, California, right now?
We're a remote company. I live up in Ventura County, but we're headquartered down in Irvine. Yes.
Yeah, and do you think some DSO will be if you what's your exit strategy if you build this up and you get private equity or whatever? Do you think a private equity would want to merge this into a DSO, or where do you see your exit strategy?
Well, the exit strategy could come from a lot of different directions. I could spend a long time talking about the payer world. Won't bore you with it, but
wouldn't bore me.
Well, the reality is, as payment for healthcare continues to change, as financing for healthcare continues to change, if the straight line had happened with the Affordable Care Act, it didn't, but it's crooked, but it isn't. It hasn't ended yet. But standalone dental companies are going to be a little bit in trouble. How does a standalone dental company sell? Well, I've got a marketing and sales crew on one hand, and I've got an administrative staff who I'm oversimplifying this, but basically pays claims and manages the payment of those claims on the other hand. There isn't a whole lot of difference between the good guys, between the administration of claims and the payment of those claims. So a lot of the difference is on the front end of who does a better job of marketing and selling what they have. And of course they're marketing and selling their ability to do the back end, so I'm not separating the two. But the point is if you take away that front end, that marketing and sales components from a standalone dental company, and you merge in medical and dental in some way that the financing mechanism pays for both. So now we've got a coverage that is both medical and dental in some way, which is where the ACA was moving things. Now all of a sudden, the dental company, the standalone dental company, is at the mercy of the medical company. So that medical company can potentially go around and bid each one of those dental companies down. I'm really looking far ahead here, but they could go to a Delta Dental and say, I want to pay X for this, and then they can go to a United Concordia and say, I've already got a bid on X. Can I go X minus? I can then go to a MetLife and say, et cetera, et cetera. So that puts them in a bind as to what it is that they have to offer. And so inevitably, in my mind, this is one person, but inevitably in my mind, that's exactly why Guardian is going around buying up the delivery system potentially, and others are going to have to too. They need to become the delivery system, not just the administrators of the delivery system. So if I've got a network of dentists that Delta's maybe a little bit bigger than Guardian, that's maybe a little bit smaller than United Concordia, who knows? But if that's my only differentiator, I don't have a whole lot of differences. But if I own that network and I can offer that medical company something more than just claims administration, that's important. So if we've got a network of dentists that are doing teledentistry, that have the ability to do second opinions, that have the ability to work with hygienists out, a DSO of hygienists out in the field, that have different means of offering services to if you got a hygienist network, potentially you could be taking impressions out in the field, all sorts of other opportunities. So this is a very easy network for a payer potentially to get involved in. So that's one exit strategy. The medical world. Again, if medical groups, dental could be a very big component of what they're offering. So whether that's, Kaiser's doing something on their own, but if Kaiser's successful with dental, others are going to begin to looking, how do I get into this business and what does that mean? So there's a lot of potential exits, and we're not worried about that. We're worried about making this thing succeed.
Is it strange when you're trying to do business ventures in the dental world to have such one of the largest players, Delta Dental, being a nonprofit? There's not really. Are there even any pure play dental insurance companies? Guardian and United Concordia, dentistry's just a small portion of what they do, correct? Dentistry is only 5% of the total healthcare budget. Are there any total pure play dental insurance companies, publicly traded or that just do dental insurance for profit and are not a nonprofit?
Well, again, they're only a small part of the country when you're talking about a MetLife. But at the same time, if you were talking to the executives of the dental, they would have probably a different opinion about how important it is within the company and how to make it succeed. So they would call themselves pure play. Guardian would call itself pure play, the dental side of the thing. United Concordia, obviously. And then, there's other players that are pure play. There's something like Liberty Dental in California that is, they got 3 million members, mostly Medicaid, but all they do is dental. And you could go around the country. Centene is similar, DentaQuest. So there's players out there that certainly would call themselves pure play dental.
Huh. Well, so you think Richard Lee would be a good follow-up for you? Do you think he'd bring a lot more? Or do you think you covered the whole thing?
Well, he would go over it. Richard is a little bit more reticent to talk than I am, so I'm usually the one that we put out front.
Oh, you're saying shy?
He's a lot smarter than I am, but he's a little bit more reticent to talk.
Yeah, it's funny. When you podcast, I was very surprised at how many of my friends that were like big famous speakers, but when they speak, they're standing behind a podium reading their slides. But to just like free for all on a podcast. So is there anything I wasn't smart enough to ask you about, I can't believe we've already been here an hour. Is there anything I didn't cover that you wish I would have talked about?
No, I think we covered the gamut here.
All right. So for the action plan, it looks like you're looking for people from California, hygienists and dentists, to contact you if they want to learn more about this.
Well, and I would say nationally, anybody that's interested in learning about teledentistry, especially from the technology standpoint, this live consultation stuff, the appointment, we allow patients to actually get online and schedule a remote conference with a dentist. So they could, if a patient is interviewing for a new dentist, if a patient has an emergency they want to talk to somebody about in a secure setting. So again, anybody can do that nationally. We don't limit that to California. So anybody that's interested in teledentistry software, go to our website.
And
go to the website. We've got a form.
Okay, so just go to Virtual Dental Care. Well, hey, thank you so much. I mean, you're the busiest man I know in this space. Thank you so much for finding an hour to come on my show and talk to my homies. I thought this was very informative. Thanks so much. I hope the rest of your day is a rocking hot day.
Thanks. You too, Howard.